Medications. I'm not able to advance. Should I just, is this working or did you do it? Okay, I'll just ask you to advance the slides. So we're going to talk about weight gain from antipsychotic medications, and I want to tell you a short story. When it was a very memorable, one of the most memorable lectures in my entire life was the first lecture of my first day of orientation as a resident in psychiatry in Oregon. I had a few mentors there who had practiced in the days before we had antipsychotic medications. So I had the great benefit of being lectured that first lecture by one of those person who had seen the entirety of the psychopharmacology era from a front seat point of view. And one of the things he said almost at the beginning of his lecture was, and frankly, I think you should take every single one of these medications that you'll be prescribing. And we all looked at him like that was crazy. And he did this, of course, for a fact. And he says, now, yeah, I see how you're all looking at me, but I want you to think about that. Let's move on to the next slide, Claire. I want you to think about that. If you're afraid of taking these medicines yourself, think about how that means, what the meaning of that is when you're going to be insisting to your clients that they should take these medications. So how many know, you don't have to raise your hands because I know what the results of the poll would be. Would you sign up for a 6-month test drive of Zyprexa? I could set you up with prescriptions. You could take it. I could even give you a long-acting injection of the Zyprexa, and you'd probably say no. And the reasons you would say no is because you'd worry about being sedated. You'd worry about the possibility of having neurological side effects like dystonias. It's a medicine that's used for psychosis, and it comes with a certain amount of brand tarnish or stigma because it's associated with that use. You might worry that you might not think as clearly as you're used to, possibly due to sedation, and you would probably worry about the likelihood of gaining weight. And if you were on it for 6 months, you very likely could gain 20 pounds, potentially more. So, I know you already know this, but I think it's helpful just to reiterate, your clients have exactly the same fears. And I think it's really important to acknowledge that if you're afraid of my offer to prescribe you a test dose of Abilify, Seroquel, what have you, it does have meaning. So let's move on to the next slide, please. So with that in mind, I just would like to offer you what I call 3 simple basic rules for pharmacotherapy. The first thing, every medicine, any medicine, can cause any side effect to anybody. So there are the common side effects and there are the uncommon side effects. So keep in mind that can happen. I once was involved in a consultation where a person was prescribed one of the medicines we'll talk about today, Metformin, and he became extraordinarily sedated to the point where we would call it obtunded. And that's not listed as a side effect for Metformin. So after hours of an academic medical center, the guy was said to be suffering from depression. And the thing that everybody missed was that, in the history, he had that side effect literally within 4 hours of taking his first dose, and it got worse with every dose. So it's even uncommon things can happen. And if you do this long enough, you'll understand that anybody can get any side effect from anything. The second thing, I think in these days, as I survey practice, we have with every medicine that's approved, we have actually very detailed studies to guide our thinking about the likelihood of side effect A or side effect B or side effect C. We actually know this as from safety studies. But it's very rare that we have good side effect data when medicines are combined. There's a handful of data for FDA-approved medications, such as Abilify in combination with a serotonin reuptake inhibitor, that can help us to know, or at least anticipate, the likelihood of various side effects. But it's rare, it's extremely rare, and for a combination of 3 medications, I'm pretty sure that the information we have about safety consists of 0 studies. So increasingly we see individuals that are taking 2, 3, or 4 medications concurrently. Oftentimes these are psychotropic medications, and just keep in mind that they're in uncharted territory. So ideally, we would try to avoid polypharmacy, in part because we have no data on the safety of the practice, and as well, we have very little data about the efficacy of the practice. And we want to be sure, number 3, that we pay very close attention to side effect risk. So we need to, in addition to making sure that the client is moving toward the goals that are relevant to them with the medication as a tool, we also need to make very careful observations and pay very close attention that side effects aren't happening. And if we see them emerging, to intervene at the earliest possible time so that they don't progress. Let's move to the next slide, please. So a fairly good example of how the field of psychiatry responded to the typical, most common side effect from typical antipsychotic medications is as follows. The so-called first generation or typical antipsychotic medications, the most commonly shared side effect was extrapyramidal symptoms. And just for benefit of review, when we say extrapyramidal symptoms, we're talking about drug-induced Parkinsonism, which looks like shuffling gait, reduced arm swing, or tremor. We're talking about dystonia. That's also an extrapyramidal symptom, and that is muscle stiffness or cramps. We also include akathisia, which is a sense of intense inner restlessness, sometimes accompanied by a lot of movement, but doesn't have to be so. It can just be a subjective experience of intense restlessness or distress, and tardive dyskinesia. So those are the extrapyramidal side effects. When it became known that this was a set of commonly occurring adverse effects, the field of psychiatry stepped up. Psychiatrists would routinely prescribe anticholinergic medicines, the most common of them being benztropine, which is branded under the name Cogentin. Notably, Cogentin has no bona fide psychotropic use. Actually, it causes memory impairment and risks delirium. So it wasn't a psychiatric medicine, but nonetheless, everybody was prescribing it. Similarly, propranolol, also known as Inderol, is a fabulously useful medicine to treat akathisia. It is not a psychotropic medication. In fact, if it has a psychiatric effect, it may be to produce depression. So it's decidedly not a psychiatric medicine, but people prescribe it all the time for the benefit of our patients to reduce their experience of side effects, to make the use of medication pleasant and tolerable so they can achieve the goals. Tardive dyskinesia, a lot of thought went into how can we prevent that from happening, and vitamin E, as well as a whole bunch of other agents were proposed as ways to mitigate tardive dyskinesia risk, and that vitamin E and other agents are not approved by the FDA, but that didn't stop anybody. We would still do this stuff. And we encouraged a culture of practice that both psychiatrists and case managers and psychologists and everybody was aware that we are going to encourage the lowest possible effective dose. If a person has been stabilized on a dose, we're going to eventually explore lower doses. And overall, we're going to try to minimize the use of these medications and minimize the exposure of individuals and the population to these drugs, because we don't want to create tardive dyskinesia. So let's talk about that next topic, about reducing the, I'm sorry. Yeah, I got ahead of myself. But now let's compare how the first generation response was to the response of the field to second generation drugs. Yeah, next slide, please. To the second generation drugs. So the most common of the second generation drug side effects is weight gain. Weight gain, which can lead to insulin resistance, which can lead to intolerance of glucose or frank diabetes, occasionally a diabetes-like crisis called diabetic ketoacidosis, along with other changes like hypertension and cholesterol changes, which collectively are known as the metabolic syndrome. Obesity is, I shouldn't have to say this, but obesity is a big problem. Obviously, nobody wants to carry extra weight, but also studies show that fat cells, especially within the abdomen or the intra-abdominal fat, actually releases inflammatory hormones, which probably accounts for observations that antidepressant drugs become less effective as the body mass index increases. There's also an entire there are textbooks written about the idea that inflammation can be a cause of psychotic experiences. So obesity is bad on its face because of the health risk and the fact that nobody wants to carry extra weight. But it can potentially make symptoms that we're trying to solve become less responsive to treatment or to outright happen. As well as people will just simply stop taking the medicine, and we lose the opportunity to move somebody toward firm and established recovery, and instead expose them to the risks of recurrence of psychosis or prolonged psychosis with all manner of risks attached to that. So it's bad. So how is the field responding to this, the leading side effect of our day? Well, we tend to tell patients or just lecture them, eat right and exercise more. And that, from my observation of practice, is probably the most common intervention. And of course, it's the one that almost nobody actually does. There's actually no shortage of medications, and we'll talk about 3 candidates later on in this lecture that can reduce weight. Some of them, Metformin and Liraglutide, actually are approved by the FDA for weight reduction, in the case of Liraglutide anyway. Yet psychiatrists tend not to prescribe them because they're like outside the scope of our practice, so they're not psychotropic medications. And they also invoke the "it's not approved by the FDA" excuse, but these are modern excuses. These weren't concerns in the first generation era. And we should be encouraging, and I think at least with lip service, sometimes we do, encourage the lowest dose prescribing, dose reduction after a period of stability, and minimizing the use of these medications and the exposure of the individual and the population. So now to the next slide. How are we doing at reducing the exposure of the population to antipsychotic drugs? Well, here's a chart from Nature, not a shabby journal, which documents a 1,200% increase in the prescription of antipsychotic agents from 1993 to 2007. 12 times increased use of these drugs, largely off-label, increasingly for things other than the treatment of schizophrenia. For example, depression, agitation control, use in the so-called autism spectrum, and these other sorts of things. So it's not a problem we're going in the opposite direction. Stealing from my thunder at the end, if we're increasing by antipsychotic use by more than 1,200%, we should be increasing our efforts to mitigate weight loss by about 1,200% compared to 1993 efforts. And I'll assert probably I haven't seen that level of effort so far. Let's move to the next slide, please. So just to be clear, it's, again, weight gain is a leading cause of treatment non-adherence. Not only non-adherence, but just non-starting. People won't take these medicines because everybody knows that these medicines cause weight gain. So the lack of attention to this very serious issue actually works against public health interests, in that if psychiatry is known as a profession that prescribes these medicines that make people fat, but not as a profession that prevents that fatness, then we get less people buying into what we have to offer, and you have more people with untreated or undertreated psychotic illness. Notably, for first episode use, the weight gain from antipsychotic drugs can be extraordinarily rapid in some cases. The risk does go up substantially the younger their person is, such that children and adolescents have substantially higher weight gain risks than somebody who is perhaps in their 30s or has had 15 years of chronic illness. And it does seem related to these first 2 occurrences that weight gain can be a greater concern in patients with first episode psychosis. So next slide. So this leads us to recommended strategies. First and foremost, to preferentially choose medications attached to lower weight gain risk. We'll talk about behavioral treatments. We'll talk about some pharmacological adjuncts, and we'll talk about the need to regularly monitor weight and metabolic parameters. So these are the 4 pillars, or 4 main thrusts in how to manage the weight gain risk from antipsychotic drugs. So next slide, please. Lower risk medications. Next slide. There are many tables, and this is one that my colleague Sarah Dugan has produced. These tables rank antipsychotic drugs according to likelihood or probability for inducing clinically significant weight gain. The actual definition of clinically significant weight gain varies, but it seems to revolve somewhere around a 7% increase from the baseline body weight. Top of the list are clozapine, olanzapine. The middle column has 2 pluses, and the bottom tier has 1 plus. 1 plus means that your risk of weight gain is between 0 and 10%. Which is great if you treat 100 people with one of those agents, that maybe no more than 10 will have clinically significant weight gain. But if you happen to be one of those 10 people, you could still nonetheless gain 20 to 60 pounds. So even though it's a low on the list, keep in mind that that doesn't mean the risk is 0. So we should, we should minimize risk, but we should pay attention to the fact that that doesn't equal negation of risk. So to the next slide, please. Behavioral treatments, next slide. The bottom line is, by behavioral treatments, we're referring to strategies that involve education around nutrition, setting up strategies to help people reduce the intake of simple carbohydrates and utilize the other lower calorie or lower glycemic foodstuffs. As well as to not only just educate, but to facilitate the enactment of nutritional guidelines, as well as to not just educate, but to facilitate the engagement in regular physical activity. And this slide is it's a bit complicated. The graph toward the right of the figure show mean differences. All of the stars or all of the diamonds are to the left of the center line, meaning that the average result from each of the studies that are listed in the table showed an ability of the intervention to reduce weight. And what they say mean difference is actually the difference between treatment group and the comparison group, and the weight loss is in kilograms. So a kilogram is about 2.2 pounds. So when you see minus 10 on the x-axis, that actually is minus 20, actually minus 22 pounds of weight loss. Another thing about this graph is that each of the diamonds in the center of the line is the arithmetic mean of the difference, but that horizontal line on both sides of the diamond is what we call the 95% confidence interval of the mean. So that's different. That's a much narrower range than standard deviation. The bottom line is that the line extends sometimes as far as to minus 15 kilograms for an average weight loss. So the point of all this, the weight loss from these interventions can be substantial, but the point I like to make is that there's a massive difference between educating somebody about them and actually facilitating the enactment of those things. Next slide, please. Another caveat from these studies is that it doesn't work for everybody. I mean, the data look great, but that data is subject to self-selection bias. Only the people who are interested in doing diet and exercise interventions will sign up for the studies. And data show that about a third will say, not interested in even considering that study. So the fact that you can see perhaps 20-pound weight loss with a behavioral intervention is great. The evidence tells you that, but that's not necessarily applicable to somebody who doesn't have access to or interest in doing those things. So I say this because I think that it's the easiest thing to recommend, but it's actually the hardest thing to enact. And the recommendation is based on data that is a little bit skewed toward higher favorability than might actually exist in the real world. Nonetheless, it's a fabulous intervention, and I think the best interventions that exist in medical literature are group-based. They're done in mental health clinics where groups are formed where peers can support each other, and the groups are not infrequently led or co-led by a dietitian or nutritionist, as well as a physical trainer or physical therapist. So they'll talk about sharing recipes, food preparation tips, and then they'll go hit the gym. would be an example of a typical group. Those groups are not only effective because they teach and they help to model the right behaviors, but they also can provide support and opportunities for socialization for affected individuals. So it can reinforce the message as well as have a lot of other useful benefits. So next slide, please. So pharmacological adjuncts. There are medicines that appear to work. And there's actually not a shortage of ideas. The ones that I just bullet pointed here are for which we have clinical studies to support efficacy, and I'll focus on 3 in subsequent slides. I'm going to talk about metformin, topiramate, and liraglutide. Next slide, please. Metformin is a medicine widely available. Its FDA approval is for the treatment of type 2 diabetes. It is cheap and it is effective. Actually, there are large numbers of evidence-based studies showing that metformin can reduce appetite. It does so by it does appetite reduction, I'm not sure actually, but it also reduces the absorption and the synthesis and the intra-body synthesis of glucose. But the last bullet point, it is used, has been used, and is I won't say quite routinely used, but it's used by physicians who specialize in obesity for the treatment of obesity in people that don't have diabetes. So the bottom line is that it works in the general population. And next slide, please. Next slide is another one of these meta-analysis summaries, and it tells you it works in people with schizophrenia who have weight gain or who are at risk of weight gain from antipsychotic drugs. The top panel, the top set of slides in this slide are studies in which metformin was administered in efforts to prevent weight gain from antipsychotic drugs, and the bottom tier of studies are where metformin was given to people who have already gained weight from antipsychotic drugs. Again, to the left of the vertical line on the graph with the dots and lines, to the left of that line favors a difference or an ability of metformin to cause weight loss or prevent weight gain. And similarly, those horizontal lines are the confidence intervals about the mean, which means that to the far left of that line, that's still within the actual average weight loss, meaning that people within that study could have lost substantially more than that. But on average, the weight loss was about 7 pounds. And if you follow the horizontal line fully to the left, you'll see that you get closer to a 10 pounds or more weight loss for average weight loss. So point of that, metformin works. And second point of that, a lot of studies support the efficacy of metformin. Next slide, please. And for those who are true data nerds, we have this concept called NNT, which is number needed to treat. Number needed to treat is a kind of what the statistic says. It's how many patients do I have to expose to the drug to see a drug benefit versus a placebo benefit. And NNT of 3 is a really good number. NNT of 3 means basically it works and it works really well. And it's a stronger effect for treating obesity that already exists versus to prevent. But an NNT of 10 is actually on par with a lot of other drugs that get used routinely in clinical practice. So bottom line, metformin works. Next slide, please. Oh, also, I forgot this one. Metformin also, there's not as many studies, but very intriguing ones. Metformin, people who take antipsychotic medications and who take metformin may have a reduction of the prolactin levels. And in women who have stopped menstruating due to antipsychotic drugs, metformin appears to restore normal menstruation. So metformin has another advantage. Next slide, please. And next one is talking about liraglutide. That's what it says, right, Claire? Or, I can't see the top of the slide, so I'm pretty sure I'm on a liraglutide. Topiramate, thank you. So I'm glad I checked. Now we're going to talk about topiramate data. Topiramate, probably most people in mental health know because it's used as a psychotropic medication. Topiramate was started off as a seizure drug. It turns out to probably have some benefits in reducing mood reactivity. It's used off-label for a lot of kind of agitation lot of treatment of agitation associated with several different diagnoses. Topiramate actually is part of a FDA-labeled branded medication called Qsymia. And Qsymia is a product that combines topiramate with, I'm totally forgetting the next one. So I forgot the other one, but Qsymia contains topiramate, and the FDA approves that medicine for, there are a couple of these combination medicines. I'm not hazard a guess. I'll look it up later. But the point is topiramate is actually included in Qsymia, and Qsymia is approved for weight loss. Topiramate has a well-known side effect of reducing appetite and causing people to lose weight. Topiramate is, I think, if any medicine gets used in psychiatric practice to reduce weight, it probably is topiramate. And it might not be a bad idea because there are studies in schizophrenia which show that when you add topiramate to other antipsychotic drugs, you have better results. On the other hand, anybody who knows me for more than 10 minutes will hear me say there are more than one schizophrenias. So although some people with schizophrenia appear to benefit from topiramate, other people actually worsen with topiramate, and not just in terms of the common cognition-reducing side effect, but actually outright production of psychosis. So topiramate actually can cause or exacerbate psychosis. So in my practice, I tend not to use it regularly because I don't know in advance if I'm going to help somebody get better, or if I'm going to worsen their illness, and I'd rather, I think there are other options. Nonetheless, topiramate is used, and it can be used in weight reduction. The evidence to support topiramate efficacy is less broad than the evidence to support metformin efficacy, but nonetheless, it's evidence and it's worthwhile to consider. Now the next slide, please. And this is going to be talking about liraglutide. Liraglutide is a relatively new medicine, and because it's not routinely used in psychiatric care, probably people haven't heard about it. Liraglutide stimulates an esoteric receptor known as glucagon-like polypeptide receptor type 1. The bottom line, when you stimulate that receptor, among other things, you feel full more easily. It promotes satiety. Liraglutide is the generic name of this drug. It's sold under 2 brand names in the United States. Brand name number 1 is called Victoza, and that brand is marketed for the treatment of type 2 diabetes. Same drug, different brand name. That brand name is called Saxenda. Saxenda has FDA approval for the treatment of obesity. So liraglutide is an FDA-approved medication for obesity that doesn't have to occur with diabetes, independent of anything else. And interestingly, it has evidence for effectiveness in reducing antipsychotic-induced weight gain. In the end of 2017, a double-blind, placebo-controlled trial was conducted in Denmark. It enrolled about 100 individuals. All people in the study had schizophrenia. All people in the study were treated with either olanzapine or clozapine, the top 2 offenders for weight gain. The results, after 16 weeks, aka 4 months of treatment, 60% of the people that got the active drug had normalized their glucose tolerance. And on average, again, average means that some people got a lot better results, but the average weight loss was nearly 12 pounds in 4 months. So it's, I hope we'll see more of that. Drug companies tend, as I said in the beginning, schizophrenia has a negative brand image, and so I can imagine a pharmaceutical company might not want to make a trial for antipsychotic-induced weight gain. It might tarnish their brand. But nonetheless, the point is liraglutide is showing evidence of a very strong effect in the treatment of weight gain associated with antipsychotic drug use. Next slide, please. And regular monitoring. So, you have to regularly monitor things. One study from a long time ago showed that if you simply measure the weight of a patient every time they come to the mental health clinic and show them their graph, that the people that get that feedback actually tend to lose weight or to slow down their weight gain. So simply doing that every time and showing the client where they are might be a useful strategy to further motivate them to try to do diet and exercise things. And more importantly, it keeps you, the clinicians, aware of what's going on. And when you see somebody's weight starting to creep up, you should redouble your efforts to make that weight go down. Otherwise, you're likely to have your client stop taking the medicine and not see you anymore. So I think it was 2004, can't remember exactly when, but it was in the early 2000s, the American Psychiatric Association and the American Diabetes Association got together and they made consensus guidelines. So this is a chart of at every visit, at such and such interval, we want you to do weight, waist circumference, blood pressure, and so forth. Just simply looking for the existence of side effects. How well do we do with that in real practice? Next slide, please. Colleague Chris Paxos made this graph for me. This is a slightly old data, but it shows, it was there in 2004. The yellow panel in the graph shows the enactment or the publication of the APA/ADA monitoring guidelines, and it shows actually 2 years after the guidelines were enacted, you started to see a downward trend. So essentially, it's as of that time point, we were actually not paying much attention to monitoring as broad-scale profession. There are, of course, agencies that do it better than others, but as a whole, it's something that we are surprisingly and embarrassingly inattentive to. So next slide, please. So to summarize, weight gain is not seen as such a big problem when you're not the one gaining the weight. But to the people that are gaining the weight, it's a massive problem. Nobody wants it, they'll stop taking their medicine, and that can cause all manner of preventable harm. In addition to the preventable harm of recurrence of psychosis where that might not be necessary, obesity risks well-being and risks a lot of health complications. It's the most common side effect from the second-generation drugs, and the second-generation drugs are overwhelmingly used as first-line agents. And if their use is increased by 1,200%, our efforts to reduce weight should have also increased by 1,200%. But in my observation of practice, it's something that, as I said, seems not to be that much of a problem if it's somebody else's problem to bear. So we need to very, very actively engage our patients to let them know that we know that this is a side effect, and we have strategies that we can enact to make it not happen. If as a profession, if we can get really good at this, let me back up. As a profession, we got really good at treating Parkinsonism. We got really good at using off-label, non-psychotropic medications to make sure that people could stay on their Haldol and not have these things that would be deal breakers otherwise. My profession of psychiatry and psychiatry training has really dropped the ball. We should be training every resident to use Metformin. We should be training them now to use Liraglutide, but we don't. So I think as clinicians in the field, I would encourage your prescribers to talk with us if they want education and guidance on how to use these weight loss medications. Alternately, making sure that you have good relationships with primary care doctors for whom prescribing metformin is almost as common as prescribing aspirin. These are not dangerous drugs by and large, and they're well within the purview of any competently basically trained physician to administer. So making sure that your clients have access to these emerging best practice medications would be enormously helpful. As I said, there's a massive difference between educating somebody about nutrition and exercise and facilitating engagement in nutrition and exercise. So I would encourage everybody in every clinic who's watching this to consider what you guys can do to facilitate those things. Evidence from the successful intervention studies suggests that forming groups to help clients support each other, and ideally with guidance from motivating nutritionists and physical training experts, as well as opportunities to just actively engage in exercise, can be enormously helpful. And in group settings, if you have 10 people and just one person says, I started to cut out all the white foods and I walk around the block twice a day and I've lost 7 pounds in the last 2 months, that one report can motivate another person. And if you get 2 people in the group who are seeing that, then everybody else sees that it's an achievable goal. So in order to make behavioral change, you have to understand, you have to know deep down that that is a goal that I can manage. And if you've been already demoralized by having a illness associated with a lot of stigma and not being listened to and so forth, you might not think that this is an achievable goal. But when you see a peer in a group with guidance and support enacting those changes, it can change the dynamic of a lot of other people there. And I think, and it will help change our attitude as well. If we as clinicians see an ability to prevent weight gain or to successfully see somebody lose 30 pounds from some intervention, we will ourselves believe that that's an achievable goal. The problem with not having really taken this up as a primary concern in psychiatry is that people in clinics tend to see only weight gain and not weight loss, because we're not doing the things that we need to do. So we resign ourselves to some pessimism about, well, that's just how it goes. And if we actually see this as something that with the right kind of efforts, we can make realistic gains, I think we can change our cultures in ways that will benefit our clients and better engage them and promote their adherence as well as their health and well-being, and make it funner, make practice a more fun thing to do. So that is, I believe, the end of my talk. Yeah. And as I said, I knew this was going to go on a bit longer than I would have liked, but I think it was hopefully you find worthwhile. And let's try to open the floor for a bit of questions or comments now.
Hi, I have a question.
Yes.
Okay, so when we're talking about clients who are morbidly obese with 100 and 150 pounds in excess or more, does the 7 to 10 pounds, I mean, I know it's a start and you don't lose 100 pounds overnight, but how do we inspire and motivate when we're talking about so much weight? And is the metformin something that is going to help people lose the 100 pounds over time, in addition to obviously behavior change and exercise and dietary changes? But is 7 to 10 pounds a reasonable starting point that we will see a difference in how their bodies respond to the antipsychotic drugs?
Yeah, so 7 to 10, so it's a great question, and thanks for that. So 7 to 10 pounds is an average weight reduction from a clinical study looking at the average of a large number of our participants. So for somebody who's 100 pounds overweight, a 7-pound weight loss is like, yeah. A lot of my colleagues that I try to inspire to prescribe more metformin will say, yeah, it's just 7 pounds though. That's just not worth the effort. But the average number is deceiving. On the other side, I don't know the exact number, but I was around the time, I was there at front row seat when Abilify came onto the market, and the Abilify manufacturer was saying, well, the average weight gain was 4 pounds. Or, you know, from Zyprexa, you will see in the initial 6-month studies or 4-month studies, the average person gained 7 pounds. So, you know, an average number is very deceiving because it looks really low. And when the drugs were marketed, initially they said, yeah, it's an average weight loss. It's an average weight gain of 4 kilograms, you know, 8, 9 pounds. And so we thought, yeah, it's fine. But, you know, that average number of 8 pounds gained includes individuals who gained 40 pounds, as well as individuals who gained 0. So to get an average of 8, if you have 4 people that gain 0, you have to have 4 people that gain 16. So my point is that the number is deceiving, and the average number is very deceiving, because within that 7-pound weight loss are people who lost 40 pounds. Again, that graph I showed you with those diamonds and those lines are called confidence intervals of a mean, which means the true average number, you know, could be anywhere between the top and the bottom of the bar, the true average number. Now, there's a concept known as standard deviation, which is a much broader range. So, I mean, the true average may actually be 15 pounds in some of the studies. And so much to your point, somebody who lost 100 pounds, I wouldn't say, well, you might lose 7 pounds on this medicine. I would say this medicine is shown to be effective at helping people. It doesn't work for everybody. Actually, you know, some people it doesn't work for any, but it works for every third person for whom we give this medicine. That's the number needed to treat. Every third person to whom we give this medicine realizes significant weight loss. And how much you lose depends upon, well, kind of how much you put into it. So, you know, it can be that narrative can be then a bit motivating to pay better attention to food and exercise a bit. But the second thing, if for somebody who's gained 100 pounds, that person is much more likely to have a much more substantial weight loss, because if they're 100 pounds away from the average, when you set up a physiological perturbation to move physiology in the right direction, they have a bigger, the average weight kind of functions as having a bigger pull. So, you know, somebody who's 20 pounds of overweight, it's more difficult for a 20-pound overweight person to lose 7 pounds compared to a 100-pound overweight person. And if both people start the same intervention, I would say the 20-pound overweight person might lose 3 pounds, and the 100-pound overweight person could well lose 20.
Sure.
So it's a
curiosity, though, is like with the antipsychotic medications. When you have somebody that is morbidly obese with that 150 pounds to lose, when they start the 7 or 10 or 20, like at what point do you see an improvement? And I realize that everybody's different, but at what point do you see a change or a significant improvement in the way the body uses those antipsychotic medications? Is there kind of a, I don't know, maybe that's a silly question, I don't know. But is there a point when that weight loss in conjunction with the antipsychotic medication, things start to groove for people who are morbidly obese?
So having a high amount of obesity is a theoretical concern that it might worsen psychosis because of producing a lot of inflammatory mediators in the body. It's a theoretical concern. What I can say for sure is that the person who's 100 pounds overweight is less likely to have a good response to antidepressant medication. And so, but the strength of that effect, I don't know the data on. But what I can say with greater certainty is, as the person with 100 pounds of overweight begins to lose the first 5 pounds in a context of, and getting closer to an ideal body weight is a very realistic goal that we are working in every possible way to help you achieve. With the first 5 pounds, we'll say, oh yeah, that thing that they're telling me, that seems to be working, so I guess I'll go ahead and continue. And as you go forward, sleep will improve because that person likely has obstructive sleep apnea. Self-image will improve. The spontaneous feelings of wanting to get out and move around will improve. You'll set up a whole range of environmental, social, and psychological changes which are nothing but beneficial. You don't have to invoke a drug-brain interaction to see that losing a significant amount of weight is going to set up a virtuous cycle of a lot of changes which will have a really potentially profound effect on a person's psychiatric symptoms, well-being, and functioning. So I would assert it's very much worth the effort. So at this point we have, it looks like 45 minutes of time. As I said, we are kind of fortunate. We have 2 cases that we were asked to assist with. And I will, both of them seem, should I say, a little on the complex side. So I would like to start with the one that seems to be not only I think equally complicated, but involves some degree of risk or danger. And so let's talk about that one first, and probably we'll begin to talk about the second case. And for the second case, if we don't have enough time, I would like to invite, it was Tammy, sent it in, right?
Yes.
To Tammy, if you can contact us individually. We have an echo session tomorrow that Nicole runs on integrated care, and I have the one I run next Tuesday on schizophrenia SED consults. So we can send you times and invitations to those, or depending upon urgency, to try to help you with that. So let's go though to now the first presentation from Sunny. And I think we're trying to load up the Sunny's case form. So Sunny, would you please let us know about your case?
Yeah, so this is Bill Baumkamp from the first team in Cincinnati. Sunny had to step out.
Okay.
So I'll kind of just present him. So but before I begin, I just want to make sure this client, he's not officially a first client. He's on our youth team. However, he works with all the providers he works with our first team providers. The length of his psychosis was 3 years when we got him, so he didn't quite meet criteria for first, but we figured a lot of these issues are really relevant to first clients. So I just want to make sure that before I continue. So we've had him since about Christmas time. He basically has very strong, fixed delusional beliefs that he's the second coming of Christ, that his world revolves around this belief. All of his goals revolve around this belief. When he talks about it, he's very grandiose. So he's really difficult to engage and not get wrapped up in kind of all his thought processes around this. He currently he has been unmedicated since we've had him. He's been refusing medications, and he had an agreement with the psychiatrist that if he did not show any aggressive behaviors towards mom, that we would not have to put him in the hospital. He is on community probate. However, a couple of weeks ago, he did have a physical altercation with mom, so he was in the hospital for a couple of weeks and was just discharged 2 days ago. While in the hospital, he got an Aristata injection. So the incident that happened with his mom, he was kind of pretty much just berating her, demanding that she pray with him and read Bible verses with him. She initially refused, and he got just really menacing towards her, and ended up pushing her on the couch and kind of trapping her in the living room and making her read Bible verses with him. So after that, we called probate and got him hospitalized. In the hospital, he